TopMedTalk.
This piece is presented by Michael Englesbe, Professor of Surgery at the University of Michigan.
It's an honor to be here. I want to thank Saul for giving me such an easy topic, how to get people to do things. So I've never given this talk before. If you want to see a bunch of kind of good science or data like we just saw, then this is not the talk for you. If you kind of like to read social psychology, you may like this, so I'm probably going to hit like one of you. I apologize in advance. We'll see how it goes. Full disclosure, I think Tony and I are the only two surgeons in the room. Any other surgeons? All right, good. I'm a surgeon. So how do you get people to do things? So I'll tell you a little bit about kind of why Saul thinks I may know an answer to this, and probably because, I think the take-home message from Carol's excellent talk was that it was a really ambitious endeavor that was relatively low-resourced. And in Michigan, we have a lot of resources to drive change, and that is just a reality, and makes you should ask whether my messages aren't essentially is this generalizable to where you live. In Michigan, we invest in making Michigan the best place for surgical care. It's not me, it's the people who pay for all of the health care. And as a result, care is good. That having been said, still changing people, changing surgeons, changing anesthesiologists is what I spend a lot of my time doing, and I fail almost every time. I've learned some lessons, and this is what they are. I will go through them with little clinical anecdotes. There is a whole science around changing people, and there's a series of books, and there's a whole kind of social network/psychology framework on how to drive change. It can be summarized in this: nothing really works except emotions. Even for people like us, for professionals, even incentives are hard to get to work. It's really an emotional endeavor. Data, maybe a little bit, but a lot of this is emotional stuff. So I run this thing called the Michigan Surgical Quality Collaborative. I think it's critical if you're going to go to a place and try to change practice that you have credibility. And as a surgeon, I probably have none in this room right now. So I'm a liver transplant surgeon. I'm an academic, so I write lots of papers. I run this quality collaborative. I'm not an anesthesiologist. I'm not a physician in community practice, so I don't know the challenges of high throughput care. My clinic has one or two patients. I do one operation a week at most. So those are the limitations of my practice. But I am charged with trying to make Michigan a uniquely good place for the 10 million residents to have surgical care. And with that, we work a lot with the surgical and anesthesia primary care community to drive that change. So hopefully you'll think I have credibility. But the point I want to talk about Carol's talk, that if you try to make change from your own, you kind of have to do it, I think the way Saul has done it, we have to go right to the top. I think it's really hard, particularly as a practicing physician, to kind of have credibility when you stand up and try to really drive change unless you're a leader. I think it's a lot easier to drive change at another institution. So if you want to make a big change, I think it's great to invite someone to kind of initiate that process within your institution. I think that's a key step. So credibility is point one. You need to have credibility. Know who you're talking to. Two is, and this is really for surgeons, and I'm looking at you, Tony, we are the autonomy lovers. Do not mess. Do not make me change. Surgeons, we all physicians, but surgeons love their autonomy, and they are there to take the best care of their patient right in front of them. And that is the mental model that, at least my audience of surgeons, that's what they bring to every attempt to try to change them. And strategy two is you've got to go right after that. You have to call that out as it is and basically kind of put it right out there. You don't want to change because you think you matter. Turns out you don't. So this is 2 years of data in the state of Michigan, and these are everyone who had an elective cholecystectomy, hysterectomy, appendectomy, or colectomy. And this is kind of essentially the proportional impact on patient outcomes of different factors. And the question at hand is, how much do you as the surgeon matter? In the 10% range. So what does that mean? So let's put that in context. If you do elective lap choles, complication rate's 1%. Okay? So of those, let's say you do 100 of them a year, you're going to have one complication. If you're the worst surgeon in the state versus you're the best surgeon in the state, you're going to have to do 1,000 of them for there to even be a difference. So most surgeons are pretty good, and turns out we don't have a huge impact on, and no one believes this, but you can look at it essentially in any operation. As operations get more complex, there is more of a surgeon effect. But liver transplantation, which I'll argue is probably among the most complex operations, is still only about 15 to 16%. Because there aren't really a lot of really bad cardiac or liver transplant surgeons. There's not a lot of variation. Most people are pretty competent. And I don't know how you'd figure out the anesthesia piece, but it's probably very similar. What matters? What matters is essentially patient complexity, and we know that. Comorbidities, and then the context of the care. So is it a good place to get care or not? So the take-home point here is you as a practitioner and your focus on your practice is the inappropriate focus. We teach medical students how to care for one patient at a time, and we're going to give them care, but really the focus needs to change. You need to ponder, and you work for your system. And that is where you need to focus kind of your efforts. Not saying you shouldn't take exceptional care of your patients, but so here's a little question. Picture your ideal patient. So most of us practice medicine. Picture your ideal patient. Think of some words to describe. 3 words. Saul, I'm going to make you call them out. 3 words to describe an ideal patient you would like to take care of. You're a cardiac anesthesiologist, so what would that person be? Healthy, nice, and thin. All right. Let's see. Healthy, nice, and thin. All right. I'm going to keep nice. The other two I'm going to throw out because you ruined my point. I'm going to do engaged, nice, and understanding of delay and time things because we're all running around. Yeah, exactly. So to change it around, and if you put yourself as if you're the patient and you're kind of, how are you to your system? So if the system's looking at you, are you those things? Are you nice? Are you engaged? Or are you like the patient that drives you crazy? The demanding patient who's non-compliant, who in Saul's case is obese and not healthy. But you can't really control those things. But that having been said, we work for the system. A lot of this comes around the electronic health record. Everyone gets so upset about it. Yeah, but it's not for you. It's really not for your patient. It's for the system. And the system of care drives most of the variation in outcome. The other piece we have to talk about is patient comorbidity, and that's why we're here today, perioperative medicine. So people ask me, as a liver transplant surgeon, why do you do perioperative medicine? Because that has an impact. As a surgeon, not so much so sure. I think that's where kind of we can win. So why did I say that? If I said that to room full of surgeons, they get uncomfortable, and I've threatened their autonomy, and I called out their misgivings, and hopefully, they're going to resist my message a little bit, but they'll remember it. But I think it's intentional to understand, do you have credibility? And 2 is, what's the bias of the room? And you call them right out on it. Say, this is the problem. All right, third point is emotion. So I'll tell a story about my role in the opioid epidemic. So I run a program in Michigan. We have about 12 grants, and we have about 40 staff that has just really grown up over the past 2.5 years. And it all started with a day when I was on donor call. It's the worst part of my job. And I had 3 donors in a row. So I don't remember how I got there. We got there, first patient. We had this little moment of silence, and they read this little story about the donor. And we're standing there, and there's this 20-year-old girl on the table. And anyone's done transplant, many of you probably experienced this. And, the Teflon's up. You're not really thinking too much about it. But it was sports injury in college, opioid exposure, overdose. Literally brought the liver back for my partner, went out and did another one, wisdom tooth extraction, 18-year-old girl, overdose. The third one was a University of Michigan undergraduate who at a party experimented with opioids and alcohol, presumably for the first time, and overdosed on our campus. This was in about a 36-hour time. So This was probably 4 years ago, I guess. The opioid epidemic wasn't kind of cool, I guess. People weren't really talking about it. Some of my anesthesia colleagues were starting to talk about it at my own institution. I became very interested in this, and this has prompted a big movement in our state. We were number 3 in prescribing overall in the United States. We're down to about 10, a lot of because of the work that I think our team has done. But so how does this matter to me? Well, if you're a surgeon, so it's just Tony and I I'm talking to right now, we prescribe about 1/3 of the opioids in the United States, but we prescribe it between dentists and surgeons almost all of the opioids for people who are opioid naive. So if you've never had opioids before, you're most likely to get it from a surgeon or a dentist. And among those patients, the implications of that first exposure to opioids can be absolutely devastating. So why does that matter? Because if you look at people who are opioid naive and you do routine surgery, their new persistent opioid use rate is about 6%. Big operations, like what Tony does, it's about 10%. Breast cancer and reconstruction is almost 20%. In children, adolescents I should say, it's 5%. So what does that mean? That means a year after surgery, or 90 days after surgery, depending on the study, we've written about 8 or 9 papers on this, a large percent of patients continue to take opioids every day. Among those, about 10% develop true opioid use disorder, where they have essentially admissions for addiction or overdose. So almost every heroin addict, almost every person who's in the emergency room for an overdose got their initial prescription from a dentist or a surgeon. So we are part of this. And probably the most common surgical complication in the state of Michigan is taking an opioid-naive patient and turning them into an chronic opioid user. So why did I tell you that story? That was an emotional story. And I'll tell you some of the effects we've had in the state of Michigan and why practice change has been so easy in this space, because it's an easy story that is relevant to every surgeon. And the dentists also have made some progress. So that's point 3 is essentially emotions. Point 4, and I think this is where most of us academics go wrong, is you need to show data that people care about. And community-based physicians, if you show them randomized trials, that is not my world. And I have this slide that I didn't put up, but it's essentially a bunch of people on a beautiful beach in like the south of Greece. But every surgeon thinks that's not relevant to them. Like this is the randomized trial study population. And then there's a picture of a guy who is like surfing in Lake Michigan. He has ice like down his. Every surgeon, every practitioner thinks, well, it's different where I practice. The point is, it's context specific. You have to kind of demonstrate data. Just going through trial after trial is good for scientists, but if people practice medicine, they want to hear data that matters. So this is a great study, and this was a medical student did the study. It's the number 2 impact study in the JAMA system in 2018, and it was done by a medical student. And all it was this, simple as it be. We looked at 400 patients who had a lap chole at University of Michigan, single institution study. And we basically said, how many pills did we give them? The number, on average, 46. Called every patient, 93% response rate. How many did you take? 6. Oh, that's a big difference. Why don't we just give everyone 15 pills? We did that, and now at the University of Michigan, most patients don't take any opioids after a lap chole. But we give everyone 4 pills, and it changed kind of that quickly. So it is a simple story that every surgeon in the state of Michigan kind of say, we had a problem at our own institution. It's easy to explain. Sounds like it's an easy change. People care about it because lap chole is the second most common operation we do in our state. And most importantly, patient-reported outcomes remained, actually they got better. So then everyone always asks after that, how about wisdom tooth extraction? So who has had their wisdom teeth removed or have a child who has? About 80% of Americans get their wisdom teeth extracted. No one can really tell me why, but I'm not a dentist. But I've been spending a lot of time in the dental community. Everyone asks so we started to study wisdom tooth extraction. Turns out there is really good randomized trials that patients with ibuprofen and Tylenol around the clock do actually better than patients who get opioids after wisdom tooth extraction. But it turns out in the state of Michigan and nationally, 80% of people get opioids. So we wrote this paper about a year ago, I think. And in the United States, this is kind of a large database study. 78% of people get opioids. Of these adolescents and young adults. If you take your opioids, you're 2.7 times more likely to have new persistent opioid use. So what does that mean? From a population perspective, that's almost 1 million patients a year, adolescents, young adults, who become new chronic opioid users just because of wisdom tooth extraction. About 1% of them will overdose in that year. So the point is that this is data that people are interested in, and it brings people in emotionally into the problem you're trying to fix. All right, so then I'm almost done. I've told you you kind of have to bring credibility. It's good to have someone from the outside come in. I've kind of talked about the point that you need to kind of show data that people care about. You have to tie it to emotion. But I think the most important point, and this is kind of the same point that Carol said, in Michigan, we're all about care pathways. I don't think anyone should go through care without it being part of some pathway. And in kind of things like cardiac surgery, transplant surgery, it's kind of always that way. Emergency laparotomy, we're going to have to get our act together in the state of Michigan because we haven't done that yet. Our mortality rate's about 14%. So, because it's hard. Yes. So anyway, so pathways. So I actually brought my daughter here again. Let's all this. I don't bring her everywhere I go. I have 3 children. My oldest and my youngest are with me here and in the hotel. My daughter's 15. She's, not here so I can embarrass her. She's the child my wife and I kind of worry about. She's quiet, studious. She apparently didn't speak, seemingly, from age like 12 to 14. In fact, on the flight here this morning, I woke her up at 4:45. She didn't speak to me until she voiced hunger around 10 o'clock this morning. So to graduate from 8th grade in her school, she had to do a talk, kind of like I'm doing right now, 20-minute talk, and like a capstone project talk. And we knew this was coming. In 5th grade, the only day of school she missed is the day she had to read some poem out loud to the class. She wouldn't go to school. We couldn't get her. So my wife and I were very worried about this. So long story short, she chooses the plastics in the waterways in Michigan. We live in Michigan. There's lots of water. Plastics are a big deal. And she asked me for help. And she and I go through and we make slides and we go through the data and 20-minute talk. And, it was, I won't tear up, but you understand what I'm saying. Parents are just like, wow, she's talking to me and she wants my help. And I got to appreciate her brilliance. She's like, this brilliant young woman. Made a slide. She gave the talk. I'm in the front row crying the entire time. She's rolling her eyes. So anyway, I am locked in emotionally around. I am woke when it comes to plastics. We'll leave it at that, right? So the next day or a couple days later, I go to Starbucks and I get coffee and I have a paper cup and I'm like, oh wait, I can't put a plastic lid on it, right? And I don't even want to use the stirrer, so I'm a cream and sugar person, so I'm kind of going like this. I pour like 2/3 of the thing out, go in my car, put it in there, do that again the second time. But the third time I do this, I'm in the hospital, and I realize I can't really walk around without a lid on my coffee. So I have put the plastic lid on, and now I use a plastic lid every time. In fact, there's one right there, isn't there? So, yeah. What is the point of this rant? The point of this rant is that despite the emotional tie of me and plastics, the really deep tie, I didn't change my behavior, and why is that? There's no pathway for change. You have to make it essentially totally easy to change your behavior. Starbucks has to figure out another way to deliver coffee. I'm not sure what it is, but I cannot not use plastics. So when it comes to getting people to change their practice, you have to tell them exactly what to do. Pathways aren't enough. Pathways, they have to say erythromycin, 1 gram PO, Q6 hours. It has to be very, very specific. And I think that's key. So in Michigan, so we're very fortunate. We have data flows from 70 hospitals. We have a data coordinating center. We know how people do. We know how many pills they're given. We know how many pills they take. We have an infrastructure for patient-reported outcomes. And with all of that, we can understand how many pills people take after common operations and peg it to the 80th percentile and set recommendations for our state. These are the numbers. So before we had recommendations in Michigan, the average patient got 160 pills after total knee. So it's now 50. Lap chole in Michigan was 38. It's now 10. The average patient takes 4. So this is proscriptive. You do surgery in Michigan. This is how many pills you should get. And this has worked really well, and I'll show you the data. I'm not talking about incentives, but the bottom line is we now have very significant incentives to follow this pathway in the state of Michigan, but the change happened before the incentives. So the way our program works in Michigan is Blue Cross essentially underpays every hospital by 10%. 10% of the money is at risk, and we're essentially the vendor, but we're the physicians in Michigan. That's a really important point. Nurses, doctors in Michigan, we decide how that 10% is given up. So that's the incentive payment, and it's all about driving change and improving care. It's a beautiful business model for the people in the state of Michigan. So we have care pathways. So that's this pathway for change. That is Starbucks changing the way they deliver their coffee. It's a specific, this is how you do a lap chole in Michigan. This is how you do colon surgery. And it's a proscriptive thing. We take the highest performing centers. We do take evidence. We ask them, is this pathway good? We talk to people like Tony in colon surgery. He's like, here's the colon pathway in the state of Michigan. Combination of evidence, and we go to the 3 high-performing sites. Can you edit this? Every site is given a specific pathway. It's very prescriptive. They can edit it as they see appropriate because there's variations in resources at different hospitals, but they have to follow it. They're paid based on how they follow it. We're going to do one in emergency surgical care. We started easy, so we started with lap chole. Colon surgery is pretty well worked out. Most people follow your ass by now. So this is opioid prescribing across the state of Michigan in the last year and a half. So on average, patients got 200 OMEs. That's in the top left, which is, I think, about 40 pills. And as of May, so just in about a year and a half, we were down to about 20 pills. Currently, we're down around about 11 pills. This is a statewide population, so it's 10 million people in the state of Michigan. I think as importantly, we're doing this as nurses and doctors. So things like pain scores, quality of life, patient regret about surgery, patient satisfaction have stayed stable. So I think the point of this is that these specific care pathways can be very impactful. Costs of surgery in the state of Michigan over the time period are down 13%. Nationally, they're up about 10%, and complications are down about 23%. Nationally, they're down about 10%. So costs are going down. That makes Blue Cross happy. So how many pneumonias do you need to not have to pay for this program? Not that very many. Pneumonia costs about $60,000. Here's my final slide. I think when we think about improving perioperative care or anything, some of us think about data. Data kind of doesn't really work unless, maybe in this audience it would because we're kind of evidence-based. But for the people who actually practice medicine, the CRNAs, the surgical residents, it's just one small piece. You have to tie in emotion. Why should you care about this? Opioids is an easy sell because in Michigan it's been such a devastating problem. But it's hard to kind of make that around other problems. But in emergency surgery, it's probably you could tell a good story about that. But you have to align all of this with the core pathway for care. And I think to really kind of change, you have to do all 3 in a very strategic way. Thank you very much.
Nick Majerison here. Thank you for listening to TopMedTalk. Now, make sure you've subscribed to TopMedTalk on your podcatcher or however it is that you're listening to us at the moment. And you're spoilt for choice. We're on pretty much every single podcast platform you could think of. So make sure you've subscribed. Make sure you've engaged with us on social media, Twitter, Facebook, LinkedIn, YouTube. And make sure you've signed up for our email updates on topmedtalk.com. If you get yourself there, you'll find a website that contains all of the podcasts that we've ever done, and it gives you the chance to sign up for our email updates. That way we can always get in touch with you and tell you what we're up to.